Okay, so thank you for coming. I'll be doing the first didactics today, and it's on the approach to chest pain. If you've been on my team before, rotated with me, you know that this is one of my passions is diagnostic reasoning and how to think through a case properly when you first encounter it, to make sure that you're using everything that you have around you wisely, not overusing things, not ordering unnecessary tests, making sure people only need to come into the hospital when they need to come in. But at the same time, making sure that the differential stays broad enough that you're not missing anything and you're not missing the things that can be immediately disastrous. It's always cool and fun to make those neat diagnoses, but the most important thing are the things we tend to see all the time. So with that, this is going to concentrate more, even though this is the approach to chest pain. I realized as I was making this presentation that there are 400 million things that cause chest pain, and there's no way to summarize all those in a 45-minute presentation. So I'm going to concentrate more on cardiac sources of chest pain, but we are going to cover these 6 kind of deadly sources of chest pain that can cause immediate morbidity and mortality. On that list we all remembered with PE and pneumonia, pneumothorax, and stuff like that. So the objectives of this, first off, to know the epidemiology of chest pain presentations, primarily cardiac. To know that that epidemiology, we see so many people come in for chest pain, and that's a big burden as to what American ERs are, the types of patients they see. And then to list and discuss the important symptoms, to review the elements of the proper physical exam, and then to review fundamentals of clinical reasoning, otherwise known as clinical pathologic correlations. So how do we take what we see and then translate that into how we're thinking through things to make sure that we're getting to a diagnosis that is correct, or at least not eliminating diagnoses that we don't want to miss or that we don't overlook. So some of the epidemiology, to give you an idea, there are about 120 million ED visits per year in the U.S. Now, one of the reasons for that, of course, is because the American health system isn't really structured correctly in that we have people going to see their PCPs as they should. So unfortunately, EDs can sometimes serve as urgent care or immediate care centers whereby people will come in and they may get triaged with something that normally would not require any sort of hospital intervention at all. But unfortunately, this is what happens. So we see about, if you take the American population, in any given year, 1/3 of the American population is coming into an ED. Now, of course, we know this isn't true. We know that there's a lot of people who use EDs more often, and it's not just a true 1/3. But nevertheless, that number is astounding. It's just, I was shocked when I read that number. And then when you think about that, there's 8 to 10% of this is due to chest pain. So the initial complaint that someone will come in with is, I have chest pain. Now, because chest pain can be deadly, right, this is a huge burden on the system, because there are certain diagnoses, right, that they lead to very bad outcomes. Most of the people coming into EDs generally are not the healthiest to begin with. So there's a certain amount of workup that is required to be done. Even though this may be the 38th time this person has come in, we're still going to have to make sure that they're not, experiencing like a plaque rupture event, or they don't have a PE or something like that. So using different sources, this is going to translate to around 7 to 12 million ER visits a year for chest pain. So this is a very common presentation. Low back pain is a common presentation. Abdominal pain is a common presentation. Withdrawal and drug-related things are also common. But, you're looking at close to 10% of the reason that people come in, 10% of the people we see in the ER here, ERs across the United States, are going to go, I have chest pain. So we know the standard workup that we're supposed to do with that, but this is what this talk is going to concentrate on. It's going to try to delineate and give some ways forward. So when we go down there and we deal with these patients, we can make sure that we are doing everything that we can for them as efficiently and as cheaply as possible. So with all of that being said, of those 8 to 12 million people who are coming in with chest pain, there are about 750,000 myocardial infarctions a year. And of those, about 2/3, or 500,000, are going to be this is their primary heart attack. Okay, so we have about 8 to 12 million visits a year to the ED for chest pain. Of that, we have 750,000. Now, these are not people who are necessarily presenting to the ER. Total, there are 750,000 myocardial infarctions per year. And of those 750,000, about 500,000, like I said, are going to be the first MI someone has had. 1 in 4 deaths in the United States is due to heart disease. It is the most common source of death in almost every population in the United States. Cancer is higher in some specific populations, but otherwise it's heart disease. And then of all heart disease that exists, coronary artery disease is the most common form of heart disease. As I mentioned, heart disease, leading cause of death for almost all populations. You can see some populations where cancer is ahead, particularly Asians, American Indians, Alaskan Natives, and Pacific Islanders. 92, so a national survey done in 2005, many people know that if you're having a heart attack, your chest is going to hurt. Okay, so 92% of lay people respondents said yes, chest pain is associated with heart attack. The problem, though, is 50% of sudden cardiac deaths occur outside of the hospital. Now, sudden cardiac deaths usually just do not happen de novo. Usually there are some warning signs or symptoms somehow. It's not like people are just walking along and then all of a sudden they just drop dead from sudden cardiac death. There has been some sort of portent that has kind of given a clue. Perhaps perhaps you're not healthy. Perhaps your heart's not working correctly. Maybe you should get that checked out by a doctor. Okay. So considering that 50% of sudden cardiac deaths occur outside of a hospital setting, this is a sign that people are not either aware of early warning signs or they may be aware but they may be downplaying them. So this is another reason that it's really important, because these people that do present, you can see the overall bias is to not present. Okay. So I know you all know this. This is just a review. The 3 major risk factors for cardiac disease: high blood pressure, high cholesterol, and smoking. Fortunately, no one in the state of Kentucky has any of those, so that makes our job very easy. Other risk factors include diabetes, otherwise unknown clinical entity in Kentucky as well, being overweight or obese, physical inactivity, poor diet, and excessive alcohol use. So again, luckily we don't really see those at all ever. The important thing to know is when you're gathering the history and physical is that the more of what you see on this list, the more of those the patient has, if you're unclear as to what the source of chest pain may be, the more that increases their chance that the source of chest pain is going to be cardiac in nature. Right, so the first 3 are very clear giveaways. Yeah, well, my cholesterol always has been 700, and I've never really wanted to do anything about it because I'm morally opposed to statins. Okay, well, that would be a strong clue that maybe the sharp retrosternal pain that someone's experiencing may indeed be cardiac. Okay, so what are the symptoms of likely cardiac chest pain on presentation? So when a person comes to ED and you're going to start going through the differential, here are some of the important symptoms that can suggest cardiac disease, all right? And we'll cover each one of these in detail. Obviously, the most important one is going to be chest pain. That's what the entire talk is about. But then palpitations and syncope. Now, those can be present in other things, right? If someone has syncope, let's say after exercising, sure, you would want to think about pulmonary hypertension. That could be something, and perhaps there's some sort of chest pain associated with that because it's maybe they have CTEF and they have like chronic pleuritic chest pain. That could absolutely be happening. Right, but we're trying to make this things that we're going to see very often and ways to get through the differential quickly. So chest pain, palpitations, and syncope. Dyspnea. Dyspnea is going to be a very important one. Fatigue, and then dependent edema. And remember, dependent edema and dyspnea are related to each other, right? They have everything to do with the fact that eventually pressures are building up beyond the colloid osmotic pressure of the plasma, and things are just going to start leaking out, right? So those are related to each other. Okay, so for chest pain, angina is the true symptom. It is defined as retrosternal and diffuse. I don't know why that did that. And then here are some things that angina, not other types of chest pain necessarily, but angina in particular, are going to be worsened by. They're worsened by activity, emotion, and cold. Okay? So if a person's describing chest pain and they're like, yeah, when I walk up steps, it gets worse. When I step outside in the cold and I start breathing in the air, it gets worse. When I start, thinking about something that is emotionally stressful, I start feeling more pain in my chest. Okay. The key things that you would want to think of, what makes it better? The two classic things that make cardiac chest pain better are going to be rest and nitroglycerin. Right, so if rest or nitroglycerin makes the chest pain better, then that really begins to narrow the differential a lot. And again, much of this is review, but it's important to keep these things in mind as you're going through and generating the differential. Radiation, and we'll have a slide that covers where pain radiates to. It would really behoove, I think, everyone who goes through residency to know a referred pain chart. So where the organs are located and then where those organs can throw pain to. Right, because there's lots of different areas of pain, lots of different ways that people are going to come in and go, my right shoulder hurts. Right shoulder, actually, there's several different things that could be going on with right shoulder, including maybe your right shoulder is like damaged or something like that. If your left flank or anything like that, it's important to know all the different organs that can refer pain to a separate area as you're going through your differential. So where does the heart... The heart shares nerves embryologically with those certain areas, the left arm, the left jaw, the neck, predominantly on the left. So that would be a sign that this is indeed cardiac in origin. Now, one of the things that this does not hold true to is when there is diabetics, because diabetics tend to have dysautonomia in general, and because the nerves don't work as well as they should, those sensory nerves don't work as well, even the visceral sensory nerves. So sometimes pain doesn't come in the order that you would expect or the way that you would expect. Women also, so especially diabetic women, sometimes there will be no radiation to the left jaw, left arm, neck. I actually saw a case history where there was bilateral elbow pain. And this diabetic woman was having a STEMI. So even though it tends to go there, you just need to be aware that in a diabetic and in women, those do not necessarily go to those, do not get referred to those areas. Chest pain, true cardiac chest pain, tends to have a duration of minutes, and that's the way the patient will describe it. Whereas if you hear of something seconds, hours, or days, that tends to be less likely to be cardiac in nature. Okay. And then lastly, common adjectives that are used. There's about 20 different adjectives, as I was going through a physical diagnosis textbook, that pain can be described in. The four most common that are used with cardiac chest pain tend to be aching, dull, squeezing, or pressure. Okay, so when anyone uses those and you have a certain timeline, then you can begin to really filter down. Perhaps this is the source of this person's chest pain. The next is palpitations. Something important to keep in mind is that palpitations are common. They do not necessarily signal heart disease. There's lots of different reasons for palpitations, I'm sure all of you have seen on the floors. It can signify that there is perhaps an ectopic focus in the heart, or perhaps there is a ischemic portion of the ventricle that, because it's kind of twitchy, because there isn't enough oxygen there, it's going to start firing randomly. That can definitely happen. But palpitations are, they tend to happen otherwise, even in healthy people. I'm sure you've all been sitting there, and then all of a sudden you've just felt this huge thump in your chest, right? And then everything goes back to normal. You're like, oh my God, what was that? That was just a PVC, right? And PVCs happen in completely healthy people. So it doesn't necessarily mean that heart disease is present. It's important to evaluate, and this is for all patients with everything, it's important to evaluate, have there been any recent medication changes, or have they changed the amount of caffeine that they may have been drinking? We all know the classic board question. A 28-year-old female who's been taking no dose for 3 days, studying for the LSAT, presents with a heart rate of 180 and blah, 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 and then it's AVNRT. She probably didn't have that at baseline. She simply had that because she was taking in so much caffeine. So again, it's important to keep in mind lots of different things that are not heart-related can feed into this. If there are palpitations, you would want to ask, is there a history of fever, right? Because that can put you down an entirely different diagnostic route. Could the patient have an infection? Is there a low blood glucose? The reason I mentioned that, I just had a case when I was at the VA whereby a patient got transferred for having pre-syncopal events and a recent positive stress test. They came to the ER, and after we had accepted transfer from a place about 100 miles away, their blood sugar was 64. So I gave him some apple juice and sent him home because he felt better. So it's important to be able to, quantify those things as well. And then is there a history of psychiatric or endocrine disorders? Those can both are known to increase when a patient has certain endocrine disorders and certain psychiatric disorders that can increase palpitations. Something else that's important to keep in mind, some people are actually, they have visceral hypersensitivity, which means that they can just feel things inside of them more normally than other people. They may feel a heart rate and actually feel that it's pathological. That can happen too, and there's certain people that are like that. They just have central sensitivity in general, so they're more sensitive to things taking place inside of them that may not necessarily need to even be worked up. So some of the questions you consider asking with palpitations: could you count your pulse? That's a really important question to ask. If they can, it is less likely that it's something like ATAC, right? Because most people can't count up to 140 to 220 a minute. Okay, so if they think that they could count their pulse, that can give you an idea that we're dealing with something that was probably around 100 or lower. Did you have to urinate after the palpitation? Does anyone know historically what supraventricular tachycardia is associated with urination afterwards? Atrial tachycardia. So if someone has ATAC, that can be associated because you get this flood of natriuretic peptide being released because of all the stress on the atrial wall. You end up with this huge diuresis afterwards. If you take any medications for your lungs, we all know that's a common reason of tachycardia. Someone used their albuterol inhaler 13 times because they were trying not to come into the hospital, something like that. Did you flush sweat or have a headache during the attack, and did you have any chest pain during the attack? It's important to know if palpitations comport with chest pain, then that can be an idea that ischemia was also present at the same time. Doesn't mean that it was that way, but it does suggest it. Okay, dyspnea. When a person complains of dyspnea, and that is a true symptom that you've been able to glean from the history, that almost universally implies that there's been a cardiac or pulmonary source or etiology for that. Very rarely, dyspnea can be related to severe anemia, but that anemia can pretty much should be picked up by a CBC and proper interpretation of it. Okay, so if someone is complaining of dyspnea, you would want to think of cardiac or pulmonary source. Paroxysmal nocturnal dyspnea is a very specific sign that someone has congestive heart failure. It tends to happen, and the reason for that is it takes a couple hours for pressures to build when someone lays down, for that pressure to exceed what is present, like I said before, the colloid pressure within the plasma. And fluid will begin to leak into the interstitium of the lung after about 2 hours. So if someone says about 2 hours after I lay down, I feel like I have to get up to catch my breath, that is a very clear sign that PND is present. And again, PND is specific for congestive heart failure. And then you would want to do, just to make sure you get the timeline right, attempt to quantify how much the dyspnea has changed. Right, I was able to walk 6 blocks, 3 months ago, and now I can only walk 1 block. I was able to go up 4 flights of stairs, and now I can only go up 2. That can give you a sign that perhaps there's something that, let's say a person has pulmonary hypertension or severe aortic stenosis, or, and that may be causing pain. That can give you an idea moving forward that this is actually progressing at a pretty good clip. And perhaps this is going to require a little bit more intervention rather than just a quick outpatient follow-up. So with syncope, there are many lectures that are available for how to work up syncope. One of the most important things to do with syncope, of course, is to find out what the person was doing before the syncopal event and to find out exactly the history before. So if, like I said before, if this occurs, syncope occurs directly after activity, these are the big things that you would want to think about. There should be something in the history that would be able to suggest that that is the route you should go down. If they were going to the bathroom or something like that, or they just stood up from having a bowel movement, that might suggest that this is vasovagal in nature, which of course we know most of the time it is. Most of the time we have no idea why people passed out. They just do, and no matter the workup we do, we're not going to find out. But at the times we do conclusively say this is why you had syncope, vasovagal is going to be the most common. Neurogenic tends to be more obvious once you get the image, right, and you have some sort of history as to find out, what exactly happened around the time of the syncopal event. The position which precedes the syncope is important. Okay, did the patient just stand, as I mentioned before? Were they urinating? Did they sit down and immediately feel better? That would be a sign of what may cause that. right? Someone feels like they're going to pass out, they sit down, they feel better. Good. Anybody else? Right, that just be a sign that someone may be orthostatic. I will not tell Dr. Parker that none of you said that, but right, that's just something you want to keep in mind, is that someone could be orthostatic. They feel like they're going to pass out, but as soon as they sit down, they feel better. The blood was able to kind of be reapportioned better within the body, and central venous pressure was able to remain elevated because they sat down so quickly. All right, so all of those things are important, the activity and the position. And then, as I mentioned before, the most common reason for syncope is vasovagal. Whoops, I went backwards. Okay, so the proper elements of a cardiac chest pain exam are going to be a 2D echo, a cath, and coronary angiography. Okay, no, I'm kidding. Okay, that's just, there are other things you would want to use. Usually that's what we tend to get. I have a feeling, though, as we move forward, that echo is going to, like a bedside ultrasound, like a handheld wand, is going to be standard for all residents in about 10 or 15 years. That's going to be a pretty crucial element of the physical exam, but at least at this point, there are certain things you should do that can really begin to give you a better idea. One of the first things that you can do if you're suspecting a cardiac source is to inspect the skin, and the temperature of the skin is a big deal, right? Generally, warm skin means cardiac output is up. Cold skin means cardiac output is down. There are other reasons for that. But again, if someone presents with chest pain and their skin happens to be warm, that can send you down a very specific road. And if they present with chest pain and their skin happens to be cold, that can also put you down a very specific road. Right, so in cold, that's basically anything which decreases cardiac output, and in this case, we'd be looking for signs that they have possible cardiogenic shock or cardiac failure. If the skin is warm, we know one of the things that we look for, let's say someone has fevers, rails, and their skin is warm, right? They may be beginning to develop sepsis from pneumonia, right? And they might be in the initial hyperdynamic phase of sepsis. So the temperature of the skin can give a lot. Are there xanthomatous present? Right, if there's a heavy burden of xanthomatous, that would increase your likelihood that there may be a cardiac source, and this may actually be a plaque rupture event, because those tend to be found where cholesterol levels, LDL, tend not to be, or triglycerides tend not to be controlled. Is a rash present? And then sometimes, we don't see this very often in adult medicine, but congenital heart conditions can present with congenital facies because elements of the arches of the face and then the heart will develop at around the same time. So for auscultation, we could spend an hour just going over auscultation of the heart. You know, when you take your boards, your ITE exams, you're going to get those particular questions. This murmur appreciated best at this place that sounds like this, that gets better when the patient stands up, and worse when the patient squats, right? We're all going to get questions. We know you're going to see questions like that. But some of the things to keep in mind with auscultation: when you're using the diaphragm of the stethoscope, you would want to press very tight against the skin. And when you're using the bell of the stethoscope, you want to press very lightly or just let it rest against the skin. That's how you're going to get the best sounds from those. With the bell of the stethoscope, you can best hear gallops and aortic stenosis. And then with the diaphragm, you can best hear events during systole. And then if you're suspecting a regurgitant murmur. Okay, so if you see something like that, you would use the diaphragm. Pay attention to the breathing. If things get louder when inspiration occurs, this is generally going to signal that the event that you're listening to is on the right side of the heart. Okay, and that's just due to an increase in preload. All murmurs during diastole, at least in our age range, are considered pathological. And then it's also important to know murmur intensity very rarely relates to the actual clinical severity of something. So you can hear a murmur, but that is not going to translate into this person sitting in front of you and the symptoms they're going to experience. You know something's wrong, but you're very rarely going to be able to get the severity of it. So murmurs are defined as harsh rumbling and blowing, and these are the different circumstances which you're going to see these types of murmurs, depending upon the way that you describe them. This is what those actually mean. And then ejection murmurs are always diamond-shaped, right? They get bigger and then they get smaller. So if you're ever suspecting an ejection murmur, I want you to think of crescendo decrescendo. Okay, all ejection murmurs are going to be in that shape. So for the blood pressure, One of the important things to get, shout out to Dr. Parker, make sure that if you're suspecting orthostasis at all, that you get orthostatic blood pressures. It is now, a recent paper came out showing that the best time to do that is right after the person stands or within 1 minute rather than waiting the 3 minutes that you may have heard about in the past. And then when you hear the carot cough sounds, that's the reason I mention those is because they're related to the auscultatory gap. And that carot cough sounds just simply means turbulent flow. Right, you're compressing the vessel so much that no blood will get through. And then as soon as you let up on the cuff, some blood will get through, but it will flow in a turbulent manner. You hear that first. And then blood will tend to become more laminar, so you will smoothen that out. And then eventually you will open up the cuff so much that the blood will flow through completely smooth, and you can no longer hear the blood pressure. The area in between then translates to what the blood pressure is. So as I mentioned before, the auscultatory gap, that's where you hear the first sound and then it goes away and then it comes back, okay, the auscultatory gap. That can signal severe chronic hypertension. You would also want to consider aortic stenosis if the rest of the picture would fit, okay. So you hear a heart sound like at 170, it goes away, and then you hear another heart sound, carot cough sound at 150. And then these are the increases in paradoxical pulse. And they're associated really with anything that is going to increase the effort of ventilation. So the exam for edema, estimate the jugular venous pressure. The normal is 6 to 8. And then one of the things as I was going through preparing this, if the abdominal jugular reflux is present, then that is a sign that the wedge pressure is at least 15. Okay, and there was like an 86% concordance on that. So if you are able to get abdominal jugular reflux, where you're pressing on the liver and the sinusoids of the liver are emptying both up and down, if they empty into the jugular vein and you can see them, then that can signify that the wedge is elevated off its normal high normal pressure of 12. Okay. You would want to listen for crackles in the lungs. Coarse means there's larger airway disease, and fine crackles means there's interstitial disease. And then you would want to look for dependent positions for edema. One thing to remember, I know my intern year, I was checking for dependent edema in someone's leg, and they were bedbound and supine all the time. So that was stupid, right? So at that point, you would want to press at the dimples of Venus in the sacrum to see if they have edema there. And then that's the place that fluid would tend to accumulate. If there are crackles in the lungs and JVD or dependent edema, then by definition there is physiologically too much fluid inside that person, and they will almost universally benefit from diuresis, right? That would signify that there is too much blood behind the left side of the heart and too much blood behind the right side of the heart. So at that point, in almost all cases, diuresis would be appropriate. So with chest pain and clinical reasoning, you need to consider the 6 conditions that quickly lead to morbidity and mortality. And we've all covered these. We all list these, but I'm just going to go over some clinical pearls that can help as you're going through these 6. First off, for pneumonia, it's very important to consider the amount of reserve the patient has. You may have seen a healthy 35-year-old comes into the ER, and they seem like they're a little sick, but everything else is fine. You get the chest x-ray, they have this massive whiteout of pneumonia. Their white count is 19, but they're sitting there and they don't look toxic, right? And you may see a 75-year-old with multiple comorbidities. They come in, they have this little, infiltrate on their lung exam. Their white count is 13, and they look like they're ready to expire, right? So it's important to keep in mind that the amount of reserve that a patient has is going to determine how they clinically look when you're examining them. And the classic triad. Get the ProCal. I mentioned this because the ProCal is useful when you get it, not only to make sure that you delineate between bacterial and viral for the initiation of antibiotics, but can also be useful for the cessation of antibiotics. ProCal is not validated in anything except lung disease. So, you wouldn't want to order the ProCal for a UTI or anything else like that. At least at this point, it is not validated. It's only validated for distinguishing between bacterial and viral. For the lungs. And then risk stratify. There are many risk stratification tools. These can be very useful when you're talking with the ER, deciding the best disposition of this patient. One of the things to keep in mind from an internal medicine standpoint is we have clinic, right? And we see patients who walk out of clinic where I assume most doctors, if they saw those patients, would be like, oh my God, this person needs to get admitted immediately, all right? So because we have that benefit where we can see patients in that type of setting, we feel a little bit more comfortable with letting people leave than lots of other doctors in the hospital. So one of the ways that you can productively have that conversation is to use validated risk stratification tools, PSI, for example, that can help you be like, no, this would actually, this person's safe, this is their score, we can do outpatient antibiotics, this person does not need to be admitted. The reason I mention always get the image, I was having this debate with Dr. Casper, actually, and if you're suspecting lung pathology, always get the image. If you're suspecting cardiac pathology, sometimes you have to get the image, sometimes you don't. And we'll discuss that on the other slide. And that's just to be a wise steward with the limited resources. Papers are now, I don't know if any of you saw that, but recent papers have now suggested a 1-hour sepsis bundle instead of 3, right? So the lactate and the resuscitation with fluids and the broad-spectrum antibiotics, the blood cultures, that should all be done in 1 hour instead of 3 hours. So that's just something to keep in mind because that just saves. The faster we can do that, the more lives we save. Pneumothorax, it's important to know if a pneumothorax is primary or secondary, right? Has this happened before? Is there underlying lung disease? Is this just spontaneous? And then, this goes without saying, never let an image ever delay treatment if the situation is dire. If the person's stable, you can continue the examination, try to figure out exactly where the needle decompression would need to take place or anything like that. If they're unstable, just decompress. And then if you ever get unexpected sounds on auscultation, look for Beck's triad, which is the distended nicknames, the hypotension, the distant heart sounds, and that can be a sign that you would need, if the patient's stable, get the image and confirm the pneumothorax. The next are aneurysms and dissections. If you have, this is obviously assuming the patient's stable and you have, I'm going to get the blood pressure in both arms now to make sure to see if this is a dissection. If you have time to do that, great. When I was talking with another attending here, they said the thing that they would simply add to this slide is call the fellow. Right. So that's just something to consider, is that it's important if you're suspecting that any of these things are so deadly that they're causing you to think, oh my God, this patient may die, just elevate that, right? I know you all know to do that, but sometimes it's fun to, fix things and be the doctor, but make sure you escalate those things if you're ever curious as to how the case could truly turn out. Usually what you see is a lower blood pressure in the left arm, and that can signify that perhaps a subclavian artery on that side is involved. If you're ever concerned both may be present, we actually had a case, I think, last year where we were concerned both were present. If at all possible, do not administer thrombolytics. They double mortality if a dissection is present. So just wait on that. If the pain moves, this can be a sign that this is a dissection and there's not necessarily a concomitant STEMI or something like that. And then a bedside echo is invaluable. The last thing, and this was gleaned from several sources, if the exam is bland, but the patient is screaming in chest pain, but the troponins are normal and everything seems normal, let the dissection rise to the top of the differential. Okay, that's the next thing that you would want to suspect if, everything seems fine. The heart, the blood pressure, I don't know, everything seems good, but this person seems like they have really genuine chest pain. Really let that rise to the top, and then don't go forward until you can rule that out. For a PE, get so many lectures on this, I'm not going to belabor the point, but these are the different things you can do with a PE. The most common symptom is going to be shortness of air, and then the most common sign is tachypnea. The second most common signs after tachypnea are going to be tachycardia and fever. Okay? But the most common thing you're going to see is someone saying, I feel a little short of air, and then you're going to see them breathing fast. Cyanosis and syncope tend to signal either a massive or submassive PE. Pleuritic chest pain tends to be subsegmental or smaller. Here are some of the EKG things you can look for. I did not put down S1Q3 T3, even though that tends to be the thing that is tested on, because that's only seen 15% of the time. Just look for any sign of right heart strain. Okay, and those are the different signs of right heart strain. If severe dyspnea, you get a normal chest X-ray, let PE rise to the top of your differential. Okay, if the chest X-ray just looks bland, but you definitely notice severe dyspnea on exam, that's where you would want to let PE just kind of float to the top. STEMI, This can be useful when talking with the ER. You need at least one value of a cardiac biomarker, preferentially cardiac troponin, at the 99th percentile, and to rise or fall off that number. In addition to that, you would have one of the following things. So, Q waves, ST elevations, symptoms, anything like that. If concern is present, always contact your attending or fellow. Just thought that would go without saying. And then one of the things that I don't see us do, but I do see maybe some staff do more often, is they'll keep the oxygen too high. If there is presumed STEMI, there's no need to keep the oxygen above 94, and actually you have worse outcomes when you titrate oxygen to above 96 to 100. No one knows why that happens. They postulate it's because of the production of free radicals. But nevertheless, you don't need to keep the oxygen above 94. Aspirin, even if a patient has a listing as intolerant to aspirin, give them aspirin. If they're allergic, then you'll have to do something else. But only if they have a known allergy to aspirin, that's the only time you would not give aspirin. And then as quickly as possible, you have to differentiate between left and right-sided. That's going to require much more in-depth workup, probably with help from the fellow, because that's going to change management. And then lastly, you have mediastinum. In mediastinitis, there's usually a history of involvement or procedures within the mediastinal compartment. Very often, a patient who has mediastinitis will look toxic, and they will have a fever that is pretty impressive. And other things you would want to look for would be like a trench, used to be called trench mouth, or now would be called very poor dentition. There's not really any natural stopping points within the fascial planes as you go from the mouth to the mediastinum. So infection can spread very quickly here and become necrotizing. So if a patient looks toxic, they have pain, or there's erythema here, that's one of the things you would want to consider. Then esophageal rupture. Hematemesis is usually not a predominant symptom of this, and there is usually some sort of initiator to it, even forceful swallowing. So, last couple slides. With the chest pain and clinical reasoning, for suspected lung pathologies, assuming the patient is stable, always get an image. That's always appropriate. Okay, that will help you go down all the different ways, all the different pathways for lung pathology. For cardiac pathologies, an image may or may not be warranted. So, in this case, crackles and suspecting heart failure, yes. But if you have troponins, right, and crushing chest pain, you do not need to get a chest X-ray off that. Now, that was the conversation that Dr. Casper and I were having. Some attendings do believe that you should always get a chest X-ray whenever you have anything involving this area, but it really doesn't add to management at all. So that would be something you would want to work with your fellow and attendant on. If a new murmur is present and you are for sure going back to the history that it wasn't, or you didn't hear it yesterday, the threshold to get an echo is very low. Okay, so just get the echo. Those are becoming much cheaper, able to be read by many more people. If cardiac pathology is suspected, the reason I stress this is a $10 test that's non-invasive with no radiation that gives you a boatload of information. EKGs just give you a tremendous amount of information, and they're non-invasive. If you're ever suspecting cardiac, just get one, and then if you get one, get a troponin with it. Okay, that would allow you to quantify things going up or down, or even if you're dealing with heart stuff at all. This is mentioned just kind of as a heuristic whenever you're ordering anything that changes value that shows damage. So as a rule, if there's anything in the body that you order through lab and it's a sign that damage is occurring, once you find that damage has occurred, you have to find the zenith. All right? So if you order CK, you have to keep ordering CKs until you find the zenith of the CK, and then you can stop ordering it. Once you find troponins, you have to go, how high are these troponins going to go? And then once you find how high they go, you can stop ordering them. Same with the lactate. So as a rule, whenever you're ordering anything in the body that shows that a cell is being damaged, you have to find how high that's going to go, and then you can stop. Same thing when someone comes in with hepatitis and AST, ALT 1,000. You have to keep going until you find how high that goes, and then you can stop ordering them. Okay. And then the progression of pain is a very strong diagnostic clue. Ischemia and infarction tend to present in a pattern that just keeps getting larger from a certain time. So as you start at time 0 and you keep moving forward, the pain doesn't tend to go away or get better. It just tends to get worse. Aortic etiologies, pericarditis, pleuritis, those all tend to present at maximum pain right at the onset. So if someone's having a heart attack, they can have crushing chest pain right at the onset. Usually, though, it's pain that tends to get worse as you move forward in time. With aortic, pleuritic, pericarditic, it usually tends to present at a 10 out of 10 the instant that the pain occurs. And then pain which goes to the back, this is something, if you've been on my team, this is something I just stress on to kind of try to tie together med school and what we do in residency. If pain ever goes through to the back, very often it's going to involve an organ that at some point passed through to the back, through the retroperitoneum. So the aorta, the ureters, the kidney, the bladder, anything that at some point was behind the retroperitoneum, those are the things that can cause pain to go backwards. This is the referred pain chart. Just some ideas as to if you see pain in certain places and you're not quite sure, this can give you an idea as to the various organs that can throw pain to those places, and that's just simply due to shared somatic nerves. You can see by far the kidneys occupy the largest area of referred pain. Okay, last thing, if pain is positional, it tends to involve architecture, and that just means a structure. So if you don't have pain here, if you don't have pain doing this, but then you have pain doing this, there's probably something wrong with a particular structure. If pain is continuous, that means there's probably an ongoing process. Okay, so we know that if the pleura is inflamed, right, it's going to hurt when you do this, but it's not going to hurt when you do this. But if you have a heart attack, it's not going to matter what position you're sitting in, or if you sit down or whatever, it's just going to continue to hurt. Pneumonia pain tends not to be severe and continuous. And then one of the things I was going to, if chest pain is present with a large pleural effusion, always consider cancer. Okay, this is the last slide, and this was just to give you an idea. One of the things that I encourage you to do moving forward is just to develop illness scripts so you can, because diagnosis is kind of art and science. So it's like playing chess, right? There are like a million openings you can do, but then at some point it just turns into an art form where you can just kind of know what's going to happen next. Diagnostic reasoning tends to be the same way. So these are 2 illness scripts. They're just chosen at random. If severe chest pain is immediate at onset, and let's say the person has a history of Ehlers-Danlos syndrome, right? Okay, that would definitely make you think that the possible aortic dissection or aneurysm is taking place. Young woman with no cardiac risk factors and gave birth a week ago, right? This is when make you just think about the differential of sudden coronary artery dissection. All right, so it's important to think about some of those illness scripts and to develop those so you can get general ideas when you first encounter a patient. And that is it.